Well, hello, my fellow dinks. Why is this night different than all other nights? Well, I'll tell you. Well, it is the first night of Passover, which is why I asked that question. So, to all of our Jewish friends out there, I hope that you are enjoying a beautiful Passover Seder or have finished your Passover Seder with your loved ones. And for everyone else that is celebrating a very holy week for most, we wish you all the best. Welcome to Dennis in the Know. This is your backstage pass for current trends, politics, and education in the dental world. As always, it is live and it is over a cocktail. Tonight it is over a lovely glass of Pinot Grigio. And it seems as if the full moon has coincided with Passover and with our hump day happy hour. So the wine is very needed this evening. So we're going to have a nice time enjoying that. I'm with my besties, as always, Dr. Chad Duplantis and Dr. Jennifer Bell. You know us all as practicing dentists. We are all educators and we are all business owners, and our job is to bring all of you in the know. So, welcome to Hump Day Happy Hour. We have a great guest tonight. Chad and I have been talking for a long time. I've been saying, Chad, we need to get some medical billing on. We need to talk more about medical billing. This is such a big thing. And we have several great contributors on Dennis in the Know as far as medical billing goes. And we happened to meet up with Kandra Sellers at Chicago Midwinter last year. We said, we're going to make this happen at some point. So, Chad, thank you for making this happen. Kandra Sellers is with us. She's going to be talking medical billing in the dental environment. But first, let's get to some news with Jennifer.
And we'll go just like that. Well, thanks for that segue. It's been kind of an interesting news, actually, for the dental week. So let's talk about a few things that I think really are pertinent and folks need to know about. Maybe slightly under the radar for a good number of our folks, but the DEA released a new requirement that you all should be paying attention to. It's called the MATE Act, MATE. And that is now requiring those of us who use our DEA license on any frequency or basis to write an opioid prescription. You now will be required to attend an 8-hour opioid training course in order to allow you to continue with the process of writing your opioid prescriptions. This is in addition or on top of your requirements from your state as well. Although I will tell you at this point, if anyone is advertising to you that they have DEA approved 8-hour courses, there is no guidance yet to approved providers like the ADA, for instance, to provide this 8-hour course, what topics need to be included, what kind of ticks the box off to make this a required course. But here's the real kicker. This requirement goes into effect at the end of June. So here we are with a new requirement and it's not even legislative, a new requirement in order to keep our DEA license active and in good standing with a additional 8 hours of training that are due in 3 months. Buckle up, folks. I will keep you posted as courses get approved. I kind of think that this may get extended as per usual course of the government when these things get approved and then they realize that some of the infrastructure isn't in place. And these large institutions need time to be able to deploy the types of education required and to credential docs. I also think it's important that this is another one of those types of regulations that often has a lack of oversight. So there is noted language in this particular act that doesn't have a lot of clarity on whether or not doctors will be audited or reviewed for this particular language. When I was discussing this with another provider just the other day, I said, this is the scenario that I foresee actually becoming the issue. You write a prescription for a patient for a legitimate prescription for a surgery you've just completed. They happen to be an addict or using it on the street as well. They get into a car accident. The last known opioid prescription came from your office. And all of a sudden you're getting a call from an attorney and from the DEA wanting to see when you attended your 8-hour required course. You also probably will have to report that you have attended it when you go for your DEA renewal. No clarity yet what that will do for those of us who are due for renewal this summer. I'm just going to keep you posted, guys. I really don't know much more than you do, except that we're getting information and that there is no clarity on the approved courses currently out there. I'm already seeing advertisements in email about courses that may be available, but please understand that the DEA has not provided enough direction yet for these large conglomerates to be able to get their education together. I know the AGD, the ADA, and other institutions are currently looking at what it will take, what would be required to be included in the 8-hour course, but more details coming. There was also an interesting piece of news that came out this week as well. We've talked about the Health Resources and Services Administration, or HRSA, in the past. They put out an interesting report at the end of Q1, basically highlighting a significant shortage in dentists in the workforce, along with other medical providers and mental health and physicians as well. And the interesting thing is that they noted that we would need another 100,000 dentists in the marketplace in order to address the current shortage. I don't know about you, but I'm processing that particular data point. Also looking at the current trajectory of the cost of dental education as a whole, and trying to understand the actual demand for dental services along with the deficit of dentists where we need them. And but just be aware that now the government is looking at these shortages in the dental workforce area to figure out how they can inject additional dentists into the community, good, bad, or indifferent. Also noteworthy, we now have 13 states allowing mid-level providers to be able to provide non-reversible procedures to patients. So this could be an interesting couple of years to see how all of these things come together. Lastly, and a bit of an interesting news and more of a PSA, frankly, as I just consume the data, I don't really know how to process it and move forward. But there have been multiple cases now, two in fact, of patients on clindamycin acne topical treatments that have had anaphylactic reactions to IV clindamycin being administered during an oral surgery procedure. So fairly typical that antibiotics might be onboarded through IV when we're doing large oral surgery procedures. I think that's a common practice for a lot of oral surgeons. I think that the question then becomes how much are these antibiotics in the marketplace and how do we quantify the exposure rate? It would seem that because the patients had been on long-term clindamycin topical application, when given it in IV form, it triggered an anaphylactic reaction. Luckily, the story has a positive ending. The doctors were very aware of what occurred and reacted quickly. So no long-term consequences have happened, but certainly a data observation that warrants a little bit more understanding as we do constantly monitor and understand the risk of a growing amount of antibiotic resistance and allergic reaction as it's being introduced to the population. So with that, that's the news.
Our guest tonight is Kandra Sellers. Kandra, I once again apologize for making you wait.
Not a problem.
One of the things that I really love when I was reading her bio is she mentions the oral systemic connection, and I think that is just so powerful. She founded TIPS Medical Billing. She educates, implements processes, professionally coaches doctors and team members to the next level of where the dental professional is heading. So with that, she's very well known in the medical billing industry or segment of our industry. And I'd like to introduce you all to Kandra Sellers.
Thank you. As I'm listening to you guys talk about all these requirements and CEs that you have to take, I'm kind of chuckling in some regards because it's like Yeah, you guys are not a medical specialist, you're just dentists.
Yeah.
Yeah, we're
I mean,
not doctors.
I'm curious. I don't know what an MD, how many CE they have to take. Is it comparable? Is it, I don't know. It would be interesting to know that. But
I would love to know too. I don't know.
Well, this particular piece of it's not legislation. I need to stop calling it. This particular piece of requirement is for anyone with a DEA license that's an opioid prescriber. So it is not unique to dentists. But in addition, we have our state dental board requirements, which I am not educated enough to say whether or not the MDs have similar, more or less state requirements for their continuing education.
yeah, I mean, to be honest with you, I feel like we do more education than most professionals. I don't know. I just feel, or maybe that's just the people I hang out with, is, we're always at CEs and we're always learning and growing, and whether it's personal or professional. I don't know. I feel like there's just a travesty in healthcare in general. And I think, well, it's probably our profession too. I mean, there's crappy dentists, like there are crappy hygienists, just like there are crappy nurses. And, it's probably across the board. But I guess I've never been one of those. So I can't really conceptualize that.
I think it's unfortunately the people that we hang out with. I think, I've seen so many people that are really struggling to get the necessary hours right before licensure renewal time, and I wish that it was different, but I think that we represent, unfortunately, a minority amongst the profession, and I think that anybody who's watching, anybody who participates in this, is probably on a different level, and it goes across any profession as well, but I see so many out there that are just trying to get the bare minimum.
Yeah.
So,
Which is unfortunate.
It is.
I've never understood that, but whatever. I mean, you can only do what you can do and be the best that you can be for your patients and for your team. So,
Well,
it's what it is.
We appreciate that.
Yeah.
Let's start us off. I know you had a great question, and I can't wait to hear it.
I had a great question.
Jeff did.
Oh, Jeff.
Yeah, of course. Well, first of all, Kendra, thank you for contributing as much as you do to Dentists in the Know, and thank you for agreeing to come on. This is a topic, having done a lot in the world of medical billing with sleep apnea treatment, TMJ. This is something that we still haven't completely wrapped our head around yet, and I've been trying to do it for a very long time, and it's been a true evolution. And everyone that you turn to as an expert, they seem to be fighting the same battles as you are, and the rules change as we learn a little bit. The rules continue to change, reimbursements change. So I guess my first question to you, and I'm sure for everyone else out there, is how do you go from the world of dental hygiene to medical billing? What was that transition like? How did it happen? What was the impetus? Like, how did this whole thing come about?
And I will say, I don't see too many hygienists on your podcast. I mean, like, contributing. So I always get so much out of what you guys have to offer, even as a hygienist, because I think it's important for me to know the things that you guys are all doing. But I loved hygiene. I loved clinical hygiene. We moved from Minnesota to Illinois back in 2011. And right before we had moved, you guys were talking about sports. My sport was downhill skiing. And I started ski club when I was in 5th grade. And by 9th grade, I was a ski instructor. And from that, I segued into ski patrol. And that was my passion. That was my sport. And I unfortunately had a really bad accident on the hill while I was patrolling, and basically had an airborne skier land on top of my head. How I didn't how I didn't, die. I don't know, like could have broke my neck, whatever it was. Somebody was looking over me. I fractured my femur. I blew every ligament in my knee, and blew my other knee that had already had surgery on it. Ended up having 2 shoulder repairs, fusion in my neck and my lower back, a lot of upper extremity injuries. And it's just really, I continued to try to go back to hygiene when I was living in Minnesota, but I just couldn't do it. I just couldn't do it. Every time I tried, it just was, I would get like an immediate headache. So when we moved to Illinois, I'm like, you know what? I have got to make a transition. It was one of the hardest things I've ever done because I really, truly loved being an advocate for my patients. I loved that patient contact. But it just wasn't in my cards. So here I am. I went into coaching dental practices on hygiene, and then and really being involved in the oral systemic connection. And then my husband decided to go off of a whim and quit his corporate job, which for what we moved to Illinois for, and join me in practice management for dental, which is very, very different than what he was doing on a corporate level. But we joined forces and started doing that. And obviously dental practices, a lot of people get into a dental practice and own it and don't really understand the business part of it. So it was a great, great venture while it lasted, but we were both kind of high D's, maybe. We butt heads a lot. So I decided after 4 different times of attending a medical billing immersion course, I finally approached the speaker and said, I see a huge gap here. And that gap is these people are coming and learning for 2 days. And I think they're more confused when they leave than when they showed up. I see, as a coach at that time, I was like, I'm hearing in the industry, this doesn't work. People have tried and failed. It's getting a really bad rap, and it's got to work. I mean, you're still lecturing, so it's got to work. And I see the need, and with the oral systemic mindset that I had, I was like, we got to do this. So I approached him and asked him if he would be my coach to help me learn it a little faster, and away we went. So I just dug in. I had a really great mentor and coach. I also had a really great doctor that I have known for a long time, who said, come and bill for my practice. He was doing a lot of sleep. He was doing a lot of big surgery cases, and he allowed me to learn on his practice. And you learn by screwing up a lot. And, even though I had a mentor and coach, and let me tell you, that mentor and coach made me dig too. Like he didn't, we'd have, 30 emails back and forth. I'm like, just give me the freaking answer. Like, just give it to me. And he'd make me dig deeper. And, I don't do that to my clients so much, but it made me better at what I do. And that's what's most important. Because now I know truly what some of the challenges are, and I understand why people fail at the process. So my niche, my company's niche, is really that one-on-one implementation coaching, so that there is no obstacle that they should have to struggle through.
Kandra, let me follow up my question real quickly. The first job that you took, was it an oral surgeon that you were working with at the time?
It was not. It was a general dentist, but he was actually getting close to retirement. So he had done he's quite a leader in sleep, actually. At this point, he's really segued. He's supposed to be retired, but he's really not. He'll never retire.
Well, the reason I ask that is just because I think that there's a lot of misconception that you have to be an oral surgeon or you have to have that MD after your name to be billing a lot of these procedures. So I was hoping maybe you'd clarify that, because I think a lot of people think, well, I'm not an oral surgeon, so I really don't want to fool with this.
Well, Jeff, one step further, if I may, because that is very similar to the question that I was about to ask, is that beyond that, what practices do you feel could benefit from a medical billing expert in the realm of dentistry?
To be honest, every practice. There's something, even exams. I mean, let's talk about exams for just a second. I look at an 0120, which is commonly billed out of a dental practice. Should that be the right code for every patient? No. But we have allowed dental benefits to dictate what we bill. And so what was happening with the 0180, which, we know 80% of the adult population has some form of perio. That being said, we should be using an 0180 on all of those patients. So we should be seeing a higher number of 0180s being used. But what happened when that code came out is that dental benefits were denying it or reducing it to an 0120. Whatever they did with it. But it really got people to a point where, again, I always say people are brainwashed by dental benefits, because we have been. We have allowed it to dictate what codes we use, even though that's illegal. We've allowed it to dictate how much we bill, how often we bill, because we can only do like 2 exams per year. Now your MD, every time you see them, and it doesn't matter if you saw 5 in a day because you were in the hospital, they each got paid. It's a coupon plan, and that's all it is. And it comes with so many limitations, exclusions, and restrictions, period. I mean, there is no one. I mean, you look at one tooth restoration, one implant, you're talking about $5,000, $6,000, whatever it is, start to finish for one. That would take 5 years to complete with a dental benefit. Doesn't even make any sense anymore with where the reimbursements are, and those have only gotten smaller. So I look at exams, and I'm sorry, I get a little passionate about this. I segued off into no man's land. But, I look at exams and I see that 0120, and on average, most practices getting $35 an hour for an exam. Now, we spend an hour with our patients, and that 0120 from a 10-year-old to an 80-year-old is very different. I have to say 80-year-old now, because I'm getting close to 55, and so I don't want to say 60. So an 80-year-old. Yeah, I got to go a little higher. But that's a very different evaluation in so many respects. From a 10-year-old to an 80-year-old. But if you're billing out an 0120, you're only getting paid $35 an hour, or $35 for that eval. And, you look at all the stuff in hygiene that we do in that hour. I mean, I could spend 2 hours with a patient easily doing, oral hygiene education and true periodontal evaluation and charting, oral cancer screening. And we're not just doing oral cancer screening. We're doing maxillofacial, head and neck evaluations. We are doing x-rays and our imaging, and all of the things that we collaboratively come to a final diagnosis for our patients every single time we see them, every 6 months. And we obviously see them more often than they see their primary care, unless, obviously if they have medical conditions that they have to see their primary care. But most patients see us more than they see their primary care. And I was at my primary care not too long ago for my annual eval, and he was like, I'm going to have to charge you more. I'm going to have to upgrade this from an annual eval to a higher level eval. And I'm like, so? I mean, my medical insurance is going to pay for it. I don't care. He's like, you're just asking way too many questions. I'm like, yeah, I do that. I got questions. And, he's like, I just don't get paid enough for these. And I said, I don't know what you get paid for these. But I said, and I don't think that you understand that I help dental practices with medical billing. And on average, do you know what a dentist gets paid for an evaluation? He said, what? I said, about $35. And he's like, okay, I'll shut up. I'm like, yeah, you should. And not only that, look at your offices. Your offices are filled with equipment. We are a mini OR every day, all day. And I really was hoping that COVID would really highlight that, but it hasn't. You know, my primary care, he's got a computer, he's got a chair he sits his butt on, a chair I sit my butt on, and a table where I can either sit or lay. That's all that's in there. He gets paid on diagnosing stuff on me all day. And the higher the level of complexity in medical decision making and the amount of time that he spends on me is how he gets paid, which makes sense.
I think based upon what you've told us thus far, I've realized that I think a lot of us are pushed towards medical billing out of necessity based upon a new device or a new procedure that we offer. Whereas what you're telling me is that I gather you can come into a practice and evaluate that practice and see the holes where the money is pouring out of the practice and where you can help fill them through medical billing. Is that correct?
Yeah. I mean, you if you are doing anything other than counting teeth, if you are looking above and beyond the teeth and the structures, the jaws, I mean, as soon as you start doing a head and neck evaluation, you have crossed over into medical. And those evaluations could go to medical. But that being said, in that comes documentation. And, you know, our documentation is often lacking. And so those are things that I set up in practices as well as, you know, a medical history should really be review of systems, not what comes out of your dental software. You know, that you should be doing when I see OCS on a hygiene note, and it just says OCS for oral cancer screening. That's not enough. We didn't just do an oral cancer screening, we did a head and neck evaluation. And, you know, to your point of can we bill this stuff? There's a government statute that actually says they can't discriminate against our provider type. So, and I do come across that quite often where they do that. And especially when you first start billing to medical, there are a couple payers that are notorious for saying, yeah, we're not going to pay you for that eval. We don't pay for that dental expense. I have a really nice letter I send them and, you know, documentation, and they pay it. I mean, they can't not pay it. There are some states that have some issues with that. In particular, a carrier that in Michigan that is doing that. And I have tried to report that to the state insurance commissioner as well as the federal government. And it can't be me. It has to be the dentist in that state pushing back because oral surgeons, as you mentioned, many oral surgeons are not even doing this.
Mm-hmm.
And unfortunately,
can you give best? So I do some medical billing in our practice, and I think one of the challenges or nuances that we've had is the commingling. Like we live and die in our practice management software, and it dictates our schedule, procedures based, how we set a room, all of those things, and it tracks our production. And then I do my own internal medical billing. So then I've got this simultaneous EHR running like laterally, sending out med claims for logical medical reimbursements. And we're constantly running into this nuance of, well, where do I put it? Do I put it in the open dental software? Do I put it in this EHR over here? And how do I account for it? It just feels like we're constantly having to reinvent policies and procedural operations to try to help these two operate simultaneously. And I would say most doctors would probably say it's not worth the frustration of trying to figure out how these are nuanced together. Do you have a best practices or what you see working really well for practices to be doing this collateral billing?
Yeah, you know, I think I don't know what you're using to submit your medical claims. Are you using a clearinghouse? Like a
Practice suite. Mm-hmm.
So,
Mm-hmm.
I mean, and that's what I do with my practices as well. We use a separate clearinghouse that's just for medical.
Right.
You create the claim, you submit the claim, you track the claim through that. The rest is all is all documented in the dental software. And that's how I teach it. And then all the monies is together. All of the reports are together. And there's
So do
different
you
ways-
move,
there's
sorry,
different
not
ways-
to get nuanced, but do you move, so this secondary software, the claims are coming through process payment. Are you moving those into the accounts in the dental software to then reflect medical payment?
Yes. Yeah. So you would have a
Okay.
like you have a Visa, like you have a credit card payment or a check payment or a cash
Correct.
payment. You would
Yeah.
have a medical payment.
Okay.
You got to do a little bit more documentation, notes maybe. There's a ton of different ways. I have never worked admin, so I don't know the softwares as well as the admin person, and that admin person. If I try to tell them to do one thing, they don't want to listen to me. And they've got
Yeah.
their own way. And quite honestly, if you have Open Dental or if you have Dentrix or you have EagleSoft, there's different settings in those programs, and how yours is set up compared to a different office could be completely different. And so you have to do what works for you, which is why, I customize that to the practice, and really what do they want to see at the end of the day? Do we need to put medical codes into the system? We can do that. Do we not? Do we just attach a note to the claim, and say 0, we submitted 0 to medical, but just a teaser that we know that we submitted a medical claim. It's just a dummy code that we submitted a claim with a note. So everybody has a different way that they want to do it, and it's not for me to say on their administrative side what's right or what's wrong, as long as they're just being consistent. From a claim perspective, there's right and wrong, and it needs to be done the right way. But from an administrative standpoint and what you put into the software, that's a little bit different.
Yeah.
Mm-hmm.
Do you have frustration with the various practice management softwares out there for dentistry?
No, because I don't really deal with them.
Okay.
I really don't deal with them. I deal with the clearinghouse that we're submitting our claims on.
Okay.
That's all that I don't have. Well, I have access for a couple of my clients, but for the most part, I don't have any access to my clients' computer software. Their Dentrix or EagleSoft or Open Dental. I'm working strictly with them on medical, and I have access to their medical portal, and that's all that I have access to for the most part. So, we figure out what's going to work best for them, and then they just, they know that way better than I do. I can give them ideas and what I see work and what I see not work so well, but at the end of the day, that person that's in the front in the administrative area and in this role usually has a pretty good grasp on things and a pretty strong opinion. So that's okay.
So, Kandra, what is the process then? So somebody listens to this, somebody listens to you and says, you know what, this is ridiculous. I really should be billing medical for a lot of the procedures that I'm doing. What are the logical first steps? Because as someone who has jumped into that arena, it was especially without a true coach. We just kind of jumped in with just all in, and it was really tough on the dental team because it's such a different world. Like there is no procedure code without a diagnosis code, and then what do those diagnosis codes mean, and then do the diagnosis codes actually marry up with the treatment codes? And so it just brings on this whole new level of education that needs to be there. So my question to you is do you think it's wise to try to train your dental team that's running really smoothly to bill medical, or is it smarter to either use an outside billing company or bring in somebody from the medical world that already knows that world and already understands the nuances to do that?
All right.
A
So
lot of questions there. I'm sorry.
There's three in there. So there's three options. One, you keep it in-house. And if you have a solid team and somebody that's willing, that wants to learn and wants to excel and contribute more to the practice, I think it's always best to keep it in-house versus paying a third party. That's me personally. And you also have more control. That being said, I've seen a lot of fraud from third parties in the industry, especially in sleep. And which has made me only more passionate about what I do because of that. Because unfortunately, and the doctor that I said was my first doc that I did his billing for, I found that in his practice with the sleep group that he was using for billing. And he's like, so who's in trouble for that? Whose NPI is on the claim, doc? Yours. And he had no idea. And he's like a straight shooter and would never do anything like that. He just had no idea. And I've seen it time and time again. And I get that. A lot of people have wanted to capitalize on sleep. So there's that. Then there is, do we hire a third party? And what I can tell you with that is, if you as a practice don't understand the diagnosis and procedure codes, how they pair together, all of that, you're only going to get the result as good as your knowledge. And if you're giving the third party a bunch of trash, you're never going to see a claim paid. And I hear that all the time. We tried them, it didn't work. It's because you didn't give them what they needed to build a claim properly. And if they needed supporting documents from you, they probably didn't meet medical necessity. So those are all the things, like what I feel and what I set out to do was to close this gap between whether you're whether you keep it in-house, whether you outsource it, to get people successful at this. My clients are successful. I mean, they just are. And it's because we're looking at the big picture. And this is a marathon. It's not a sprint. So when we talk about our staff, and I'm always very cautious of overwhelming our team members with this process. Because they already have a lot on their plate. And if we bring somebody in from the outside, that's maybe a medical biller. But what I can tell you with that is there's a gap there too, because they don't understand our industry. Mm-hmm. And at one time I had a third party that was helping me with all they've always been in the medical space. And for 35 years, they've been in the medical space. They got into the dental space with sleep. And I wholeheartedly trusted them. And then I said, hey guys, I need help with surgeries. Like most of my docs are doing surgeries. So I trained their people on how to do that. And after COVID, they came back and they were like, we don't want to do this. Like, this is a whole different ball game, dealing with dentist reimbursement. And then you can bill to dental and medical. And how do we do all that? And they were just like, we're just going to go back to medical practices. And so I had to, look for another third party, and had some really bad experiences with that. And now I finally have a third party that is completely transparent with me. And our end goal is to help our clients that we collaboratively work together with. And that works. But, it's taken me a couple of years to get to that point, because I thought I was going to have to develop my own billing company, which I really didn't want to do. It's not, I enjoy the coaching part. I enjoy the implementation and seeing people be successful. I want somebody else to do the transaction. I don't, that's not that. I'm more valuable than that. I'm more.
Do you have best practices when it comes to services that could be dually billed, like billing medical first, billing dental first, just for the folks listening who are kind of dabbling and trying to figure it out?
I don't ever, when I start with a client, I don't ever say change your process, because we're going to encounter things that maybe the claim doesn't go through with this payer, and we need to figure some things out. We need to unravel the twine that has been generated from them trying with medical billing before. And that can take some time. But for the most part, we can usually start submitting and not have, start getting reimbursement right away, which is amazing. But once they start, and like you said, Jeff, was like, what is the, I don't know how you put it. I don't know how you put it, but it was
the first steps.
yeah. And how do you start this process? I mean, I don't ever want your AR to go crazy. Once you start getting more knowledgeable, and that's what Jeff was talking about, like this was like it's a mind shift set. Your mind has to shift and set a different way and start thinking more medical instead of dental. And that does not come easy. And there are still days that I call my original mentor, and I'm like, okay, I just need a reality check because I've been beat up today with questions. And, it's the reality. And, he kind of resets me, and that I am doing the right thing and I'm doing it the right way. But there is so much out there that has been negative about it. And it's just because people really didn't have the one-on-one customized coaching that I offer. To me, that is what has made my clients successful. Because again, I was one of those hygienists that attended a 2-day immersion course 4 different times by the same person. And I still didn't know what I was doing after 4 times. I had an idea, but I really wouldn't have known where to start, so it's a journey, and that's all I can say. It's a journey. And there's so many things that we do in our dental practices that dental benefits are not paying for. The patient has to pay out of pocket for, or we are getting low reimbursement, and we can recoup what we had to write off by being in network with the dental. So there's so much opportunity. And sometimes when I do my calculations, so you ask like, what are some of the next steps? I have people send me a report of the procedures that they've done for the last year. And I calculate what that looks like, what it looks like as far as what they collected, how much they got paid, how much they maybe didn't get in case acceptance because patients couldn't afford the treatment. And what it looks like if you would have used the medical reimbursement. And it almost looks too good to be true, but it's real. That's all I can say. I mean, the reimbursement on the medical side is 2 to 12 times higher than anything on dental. And I've taken that comparison from a fee schedule of a dental provider that's in network on the dental and medical side of a carrier, and side by side compared medical versus dental. It's amazing.
And that's another interesting point that you bring up, because and this was some of our struggle in trying to keep everything just in dental software and run a parallel clearinghouse program for medical insurances. Well, we're charging a different fee to the medical insurance. And yes,
you know where I'm going.
I know exactly where you're going with that.
That's what happened in sleep, and that's why I say there's been so much fraud.
Kendra, we have great editors, I promise. No, but the point is this, is that we cannot charge in our dental practices what we expect to get from medical. And that's just honesty. That's just where we are, because dental does not reimburse the same way. So when we go over to the medical side and we say, okay, we're billing this procedure, maybe we provided these extra services and this extra level of exam, whatever. But the difficulty is in bringing those numbers back over to your dental software. And that's where I really think that the coaching is so important, to say, okay, here are some best practices for doing that. I'm just trying to be as real as possible. And I know what you're saying, and we're on the same page here, but
I totally get that. And it is a complete mind shift change. But the reality is, let's just talk about a bone graft. Most of my practices, when I start with them, they are not even recouping. They're actually going in the hole by what they're charging for bone graft. And then they add a membrane on top of it. They are going in the hole on the product, let alone the expertise to do these types of procedures and the training that they have had to do and the staff that they're paying to do that. So let my one big example is always, say a patient comes in as an emergency, right? They come in as an emergency and they have a toothache, they have a non-restorable tooth, you extract the tooth. Most practices will bill out the extraction, and that's it. $300 for the extraction. The patient interrupted your schedule, blew up your schedule, got you behind, and you did a same-day surgery. You could have charged for the emergency evaluation. You could have charged for the CT that you took, because you should take the CT before you go in there and, where's the sinus? Where's the mandibular nerve? What's happening here? Like, how big is this lesion? How do we get behind? Because we don't know what we're getting into. So, plus you did a cyst removal. You actually did surgery on the jawbone and you debrided all of that and got all that infection out that was streaming through their bloodstream. And then you placed a bone graft.
Yeah.
But you charged $300.
Well, and that's my point, is that in reality, it's not that we're charging more to the medical insurance companies. It's that we in dentistry have discounted based on what dental insurances pay and what allowances are, because we don't want to see our patients get beat up that much. So now we have the opportunity to bill what we are deserved, and what the patient should be entitled to for reimbursement.
Yeah.
But there's a mismatch between what we've been billing out in dental and what we can and should be billing to medical. And I think that's the tough part here.
We have been brainwashed by dental.
Yeah.
But the reality is how many patients are going to have this thrill when they find out that the total costs may be offset by medical insurance, which the majority of them have, that don't even have dental insurance.
And how many patients? So it's, we're still kind of in the new year, right? How many, when you set your goals with your team this year, one of the biggest ones is how many new patients are we going to get per year? You're only going after people that have dental. What about more people have medical than dental? You have a whole nother subset that you could go after. You could go after your urgent cares and your ERs and say, hey, because you know what's happening there? The patient goes to the ER because they don't come to you because they know it's a tooth problem, but they don't have dental benefits. So they go to the ER because they know that the ER can't turn them away, and they probably have medical benefits. But the ER doesn't do anything for them. They give them a prescription and they send them on their way. And in there lies a whole nother problem. 50% of heart attacks and strokes are due to an oral infection, i.e. abscessed teeth, cyst in the jawbone, and periodontal disease. And I say that with research to back it, and it's the reality. I have a friend that's a transplant nurse, and she's like, you have no idea how often this happens, that people die. And we see the end result of that. Because they had an infection and, they didn't come to you in the first place. And it's such a tragedy. That shouldn't be happening. So, and unfortunately ERs they don't have dental professionals in the ER. So they rely on us, they rely on the patient to go see a dentist, and they don't, which is terrible.
I think the other big when at least I've experienced in my practice, I know Jeff treats a lot of sleep, but for me, it's trauma. When patients come in with an unexpected occurrence that happened, and sometimes these can be pretty expensive. They incur endo and oral surgery, and then there can be a lot of multi-moving parts. And when we start opening the conversation of medical billing, you can kind of just feel the relief coming from the patient to say, well, this was going to be a $10,000 bump in the road, and all the CTs and MRIs and stuff that we're taking at the ER are going to be covered, but everything that's happening in my office is going to be out of pocket.
Yeah.
When I say, but that's okay, because we medical bill here, so we're going to walk you through that journey, and you're going to get some relief financially for that. You can just feel, if you do it for no other reason than those unexpected trauma cases that walk in, there's a huge relief that comes to those patients who are going to get support and help.
That's a great point, JB. And I think we have, so Kandra, we're actually running out of time, and gosh, I could talk all night about this, and I know you can for sure, with a lot more knowledge than me. But I would love to invite you back, and because what I would really love to do is just have an entire episode kind of dedicated as a roundtable. We had actually mentioned that at one point, just have kind of a medical insurance billing roundtable. I just think it would be so interesting. I know I, for one, will try to listen more than I speak at that, just because it's something that I learn from every time we have someone that's knowledgeable about that. But I just want to say thank you for coming on. Hopefully you're willing to join us for that roundtable. Thank you for what you're doing. Yeah, because this is such a needed service, and if for nothing else, just what Jennifer was talking about, to be able to help patients, even if it's just on the trauma front. But there are so many other opportunities.
Isn't that why we have insurance?
Right.
It's for when you have trauma, when there's an accident, and
right.
And it's for catastrophic events, right? I mean, and there are insurances that exclude that, but which doesn't make sense. Or patients with cancer. I'm going to be launching a new program here, in hopefully by summer, dealing with just patients with oral cancer, and I'm super excited about that, because again, it comes back to being just very patient centric, and when you do the right thing for the patients, and the rest follows for a practice, and you feel good about what you're doing. So
totally agree. Well, is there a way that our viewers and listeners can reach out to you if needed?
Yep. Just you can look at my website, tipsmedicalbilling.com, or you can go Kandra at tipsmedicalbilling.com. If you want to go direct, that's my email. Either way.
Would you do us a favor and post those links in the comments of this broadcast?
Sure.
Yep. Thank you.
And there are some questions too, if you're inclined as a member of our community, but there's some good questions I think a lot of our members would benefit from for getting your feedback.
For sure.
Yeah, it gives us questions for the next show too.
Yeah.
Yeah,
they're just building. They're like snowballing on top of each other.
There's always a lot of questions, and that's okay. I mean, it's like I said, this is a marathon. It's not a sprint. It's not going to happen overnight. Nor is your mind going to shift into a medical model overnight. But that's where I see personally, if I owned a dental practice, I'd be looking at medical, and stop chasing the tail of $1,000 per patient.
I would agree.
Absolutely.
Well, and if you're watching the CDT,
so enlightening. Sorry, JD, I cut you off.
No, you're fine. But if you're watching where the CDT code book is going, I mean, the quicker you can start to understand diagnosis codes and modifiers and all the things
And why the heck did they add sleep codes to that for sleep appliance?
I don't know.
I don't know.
That would take up the patient's benefits right there, and then
I know.
I don't.
Right.
And
I
no
know
one's
that is
And
not-
none of them
dental
are paying
benefits aren't
for it.
paying for it anyway.
Well, it's like all the other stuff on the fee schedule. Half
Yeah.
of it's not paid for. It's not a
Right.
covered benefit. It's just a joke.
No, and
Yeah.
I think there's a very valid point in here that nobody talks about, but when we do sleep, no one sees us as a practitioner. So there's absolutely zero value for it being reimbursed by the CDT code book because the CDT and the ADA actually sees us as a practitioner. When we do sleep and make these medical devices, we're seen as a completely different entity. So now the lines are getting very blurred. Like, are we a practitioner or are we just a medical distributor of supplies?
It should have
where's that
never
line?
crossed the line into the ADA with a ADA code.
I
It should have
agree.
never. This is a medical condition. It's an
Yeah.
airway condition. We just happen to be in the front line to assess for that. We're
Correct.
the only ones that are truly responsible and see the patients to be able to save lives. So
Well, in a way, it's good because it's making both entities realize that there is such a crossover. And
we'll get there.
we'll get there.
I've I hope I got another 15 years to go, and I hope 10 years. I hope I can see an impact. I've already seen an impact and more acceptance of what we do from certain people. And I mean, I get in arguments sometimes with ENTs and stuff on the medical review side. That's a whole nother story, but it's like, you have no idea what we do. I mean, we've got value but we need to feel the value, that we're worth it, and that we should charge for the value that we provide, as well as stop giving everything away because dental doesn't pay. We have another avenue to get reimbursement. And
that's a profession shift. That's more than a paradigm shift. It's a profession shift.
Yeah,
So,
it is. I mean, like I said, I still, there's days I have that are like, dang, I just want to bang my head on the wall. And I have to get a reality check myself every once in a while. But at the end of the day, for me, it always comes back to the patients I serve. And I'm hitting a lot of patients via all of my clients, more than I could have ever done chairside.
Well, great stuff. Thank you so much for being with us. We've run everybody over a little bit, but it's for great conversation and a great cause here. So all of you, we wish you a great week with whatever you're celebrating. And to all of you out there, thanks for watching. Thanks for listening. And Kandra, thanks for being with us. So wish you all a great night.
Have a great night. Have a great Easter, guys.
You too.
Or
Take
whatever
care.
you celebrate. Bye.
Good night. And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.